I am Professor Tandon. I'm going to speak on healthcare delivery system with the subtitle on healthcare in developing countries. And before this, I would like to welcome each one of you to the EPG Pathshala today. The development team has been guided by Professor Mishra of Banaras Hindu University with his colleagues from Aligarh Muslim University. And now to start, I'm going to talk today on healthcare in the developing countries. Now for this, before we go into this, it is important to know that what are the learning objectives? What should we learn and how should we proceed? To define the goals for the health services, to enumerate the scope of health services. Now, if we want to learn about health services, we should be able to define what are the goals which have been set and what do we have to achieve. Then to enumerate the scope of health services, how far and how long or how big in width should it extend? What should it encompass? What type of services should be given? Then third one, to identify the dimensions of accessibility of health services. I must say it's a very important point, accessibility, because in our vast country, there are all sorts of nationalities, there are all sorts of geographical patterns, and to access each and every corner of our beautiful country, it actually deserves a very clean cut and a very healthy service possibility. Then we must to enlist the reasons for non-utilization of health services. For every scheme which we impose on our nation or on the people, most important is whether these services, whether it be health or any other services, will they be utilized effectively and to the extent to which we want, or will there be some reasons for its non-utilizations? And then if there is non-utilization, to whatever extent, we must go into the proper reasons and to find out effective interventions so that we could bring down those reasons and spread the utilization of these services to a more effective goal. Last one, to identify the constraints on the demand for health care, and to enumerate the determinants for preferences for healthcare and strategies for improving utilization of healthcare. See, in every nation, in every population, in every geographical area, there are some reasons why people would like to take these healthcare services or would not like to take. So as such, it is important to go into every single factor which may or may not be useful in finding out the acceptance of any healthcare program. Healthcare services includes the provision of all services that prevents disease and preserves health, extending from illness treatment and management to the maintenance of physical and mental well-being of the individual. Our basic goal will be that the person who is standing in front of us, whether he comes ill or he is well, the ultimate aim should be that he should be completely, wholly well person. And the social services comprise of the social services we want to give, which will all help together, will comprise of poverty reduction, housing adequacy, environmental sanitation, including the provision of safe and wholesome water, adequate nutrition, education, and employment. Now, if we go into providing health services, it's not only the health services which matter. The question is, what is the person standing? Where does he live? How far does he live? And besides, what is his mental status in accepting all these services? So that, and apart from that, it's not only his own mental awareness to the programs which are being given, but what is his poverty or what is his income level? What type of a house does he live in? What are his family members? And what are the problems therein? So it's everything, it's one single global problem that we have to look into before we can expect a proper acceptance of our healthcare program. Healthcare includes the factors promoting development, that is economical welfare, political support, social services, infrastructure, agriculture, education, and individual accountability. Individual accountability because it is the man himself eventually in the end, man or the woman or the child whom they have to bring in. They should come up and they should be able to accept our services in toto. The essence is to include preventive, promotive, curative, and palliative interventions, whether it is directed to individuals or to populations. So therefore, whenever we start with any program, it is important to know what can be the goals. Now, the goals of any health program, if we want to start, is most important is how do we measure? How do we measure that our programs have been successful? One is by the reduction of the mortality, reduction of morbidity, increase in the life expectancy, decrease, of course, in the growth rate of the population. Because once the population is controlled, the services would be accepted more equally. In fact, there would be equitable distribution in a more comfortable manner. Then, most important, if there are lesser number of family members, the economy can be spread out to improve the nutritional status and it to provide basic sanitation. Required health manpower would be available. Resource development and other factors such as food production, literacy rate, reduced level of poverty. Because every penny earned and every penny saved would go towards increasing the education, increasing the awareness, increasing the literacy status, and increasing the economic power of the family. In our country, not only in our country, worldwide, there are figures which show that healthcare spending by the country, it only goes to show, this chart will actually show what is the importance of healthcare in each one of these countries and how much are they willing to put into it. Now, for example, Brazil is spending 9.1% of its GDP for healthcare, whereas China, India is coming to about 5%. Japan is better off. And most important is the UK and the US to the extent of 18%, so which is actually maximum input is being put into healthcare spending as compared to the other countries. And there's one very happy picture which stands before you, which shows the 20 happiest countries in the world. Happiest in the sense because happy is a question mark. They are happy with the health services or they are happy in their health. It matters. For example, Switzerland, Iceland, Denmark, Norway, Canada, Finland, these are supposed to be the happy countries. Whereas some of the still developing nations, in fact, United States, strangely enough, is coming way below. So, because there are many reasons which I will be going into later, that people are not very satisfied with the health services. Then Brazil, Ireland, Belgium, United Arab Emirates. Although these are some of the richest countries and they have enough money to put in, the question is what is the manner in which the health services are being given. So because all this will depend on the healthy life expectancy and how it will increase and to the benefit of the nation. Now, what are the scope of the health services? Scope will include constructive services which include environmental and nutritional measures, physical society, all these actually matter because environment, nutrition, physical society, like I said, even a house matters where the person stays. These will actually afford the construction service or construction of the health services in the community. And for personal protective services, of course, it refers directly to the individual and it includes things like immunization, periodic health examinations, health education, a continuous health education, which is very essential because this is the crux of seeing that health per se would spread far and wide to each and every. So first, we have to improve the understanding of the person before we can provide the health services. Curative services comes when the person actually, when illness starts. And this will include the diagnosis and the treatment of whatever disease or injury with which the person comes in. And finally, the restorative services, which include measures to help the individuals to return to full working and living capacity. Now, for example, if a person has been injured working in the field and he needs obviously curative services, after the curative services, he will need maybe operative services. Once he goes back, it is important for the health workers of the rural areas to reach out to him, to make him feel comfortable and to explain to him the extent of his injury and wherein he can recover, so that he recovers in a 100% working capacity. Accessibility of health services. Access to healthcare can be understood in terms of geographic availability and identifying 4 dimensions of access, respectively: availability, acceptability, accessibility, and affordability. This is in fact one of the most important 4-point factors as far as health can be said, because it depends that healthcare we want to spread out to the entire nation. So number one, it has to be available. It has to be available within easy reach of every single individual whom we want to bring into our fold. Secondly, it should be acceptable, because let me quote an instance here. When the maternal and child health program was started throughout the nation, the first thing which happened was that, of course, you have to motivate the woman to get herself examined, and then you give the iron and the calcium iron tablets were given and said, please take it because this will prevent anemia. Further, apart from that, nothing else was explained to them, and the social and the worker, the health worker, walks out. Now what happens? Most of the women, it was seen in the initial days that the iron tablets, which were absolute importance to their health, because they have not been explained properly, because they were not motivated to understand, these tablets were thrown in the dustbin or in the kude ka dher outside their houses. Now, this is what happens when you want to give medicines. You have to see that acceptability is a very important factor, because it is then only that the medicine is actually reaching out to do its work. Accessibility. If a person stays within 5 miles of a health center and the house of the distance between the house and the health center is not very accessible, do we think that the persons are likely to accept the health care? No. So therefore, in order to do this, it is the work of the health center and it is the work of the health workers to see that health care becomes accessible to even to those far outreach families. And most important, affordability. If they ever have to purchase medicines, it should be said that medicines should be non-costly, but they should be of good generic medicines. In fact, in today's, let me give you another good reference today. Jan Aushadhi has started its distribution of generic medicines which have been made, screened, tested, and they're very absolutely affordable, with the result that people are now beginning to understand the economic difference between branded medicines and generic medicines. So whatever the medicine be, it should be affordable and it should be acceptable. The underutilization of effective interventions. This is where I would like to once again tell that we have health services which are supposed to reach out to every single person within his or her outreach. The question is whether all those families, at least more than majority of those families, should be able to use those services so that there is no underutilization of the effective interventions. Effective interventions in the thing that the social workers are visiting the houses, their health education is not being wasted, Their examinations are not being wasted. The medicines which are being given are actually taken comfortably every single day. And the least usage of effective interventions by the poor. Now, this is a very strange thing. The community or the income group which actually needs the services don't want to utilize the because of several factors. Number one, they feel that it is too far off. Number two, we are too poor, we cannot afford these medicines. Number three, that my mother-in-law or my family, nobody has ever gone to a doctor or nobody has ever been examined by these people, so why should we? It is not necessary. We'll be absolutely all right. So the community or the economic community which actually needs these interventions, which needs the health care, their usage is the least in them. And strangely enough, the community, the economic community of the higher income group who actually don't need so much are the ones who use them very regularly, so that there is this disparity in usage and understanding. So probably what is important is that health education, a continuous health education would be essential in order to see that our health services are utilized effectively. Underutilization of effective interventions. This is what we've been talking about. Millions of individuals suffer and die from conditions for which effective interventions exist actually. So services are there, people are there to help you, hospitals are there, and yet these people the distance from the house to the hospital is not being covered, either mentally or physically by the person himself. Why? This is probably because, number one, he may not know that these services are available and that he can be treated. For example, it used to happen in leprosy program, tuberculosis program, take any one of the national health programs, and we see that in the beginning, people never came forward, and in fact, there were a large number of useless mortalities resulting because people never utilized these services which were actually good for them. So there's a huge disparity in the field. Now, in the field of reproductive health and various communicable diseases, less than half the women get an antenatal checkup. Now, this is very important. People living in the rural areas or people living in the slums rarely get up to go and get themselves examined. You may explain to them 100 times that it is important, but for them, it is what their families did or what their mother-in-laws did. So this is important that we have to motivate them that this is today's world. Medicines are there, examination is there, hospital is waiting for you. Please get yourself examined and get a healthy baby and a healthy you at the end of it. And only 1/5 of the births are actually supervised by trained personnel in South Asia. Now, what happens to the rest of them? The rest of them take birth in their own localities, in their own areas. It is the older women, more experienced women who come and help them. Half of them have not been trained, but still those families have more faith on them rather than the trained workers. And in the low middle income group countries, for example, antiretroviral therapy coverage rates do not exceed 5%, although the medicines are there. The workers are explaining, the workers are talking to the people, and yet people don't come forward for this particular disease by which at least they could have a healthy, semi-healthy life and a prolonged life. Now, therefore, there is gross underutilization, raising coverage rates to 99% from the current level of effective prevention and treatment interventions and maternal health interventions may result in 63% reduction of child deaths and 3/4 reduction of maternal deaths. But this does not happen because, like we've been talking, there is absolutely gross underutilization of the services which are existing for these very people. Apart from this, there is a lack of demand. What does a lack of demand mean? It means cultural and educational factors may hinder disease recognition. Now, this is what happens. When people are sitting at home listening to the older women, they will always come up with this was never done when we were older, or this is not done in our communities. As such, the culture comes in, and they may not be educated, so these factors in fact hinder the acceptance of health services within their families and its potential benefits, whereas economic factors may suppress utilization. Now, what does this mean? This means that the very first thing when you say that please come to the health center, that they don't have the money, because they cannot afford to put in a little bit of their money as far as health is concerned. And in fact, they see a better return of that money buying milk for their children or buying food for their house rather than spending the money on health for oneself. Because she doesn't realize that if she is healthy, the family will remain healthy. So therefore, there is a lack of demand, there is a lack of utilization, and in fact, there is underutilization. And many studies have also concluded that 23% of the fatally ill children actually don't take any treatment at all. Either the family delays in taking them for treatment, or it is just said that the treatment, whatever is taken, is all half resource. Now, poor supply, there could be poor supply. Now, let us not only place the crunch of it on the individuals. Let us come to our side. There could be a poor supply because many times either the workers are not reaching the distant families, and sometimes, often there is a very poor supply of drugs and of injections. Injection tetanus toxoid is needed. So either there'll be old files which have been out of dated, or there could be a lack of availability of these medicines. So therefore, this also, so every time a woman comes and she says there is no medicine, so this means that our supply line has to be corrected, and first of all, we have to correct the health center part of it also. So even effective interventions are not too expensive, as interventions applied at home delivery may avoid 1/2 of the child deaths in any area. Now, poor quality leading to loss of efficacy. Most important shows that there is mixed evidence of impact of primary healthcare clinics on population health. Although the primary healthcare interventions has a high efficacy, but it is possible that the quality of healthcare being given at the center itself may not be that good. So when a person comes, instead of doing a complete examination, she may just have an abdominal examination. The BP instrument might not be working, or her urine might not be tested, or the child the weight machine might not be working. So therefore, there could be poor quality services. So once this starts, the person on the other end, our patients, are not likely to accept our services also. And therefore, there is actually a need for quality assurance and enhancement on both sides. So evidence shows that demand is quality. You give good services, the demand will rise. And the demand will mean that a lot of people are going to accept, because if one accepts, that one person could bring in 10 others, because she will go back and say that my services given to me were perfect. A survey in a rural area of India shows very low utilization of public health facilities, although they are freely available. This is what we've been talking, that the services could be there, but they may not be acceptable because of difficulties on both the sides. Now, least usage of effective interventions by the poor. Now, this is the strange part of it. We say that interventions are good for everybody, and particularly for the underprivileged community. But it is the underprivileged community who rarely or have the least usage of these benefits of these interventions. So most of the health benefits could be achieved through channelized scanty resources for the treatment of poor, through prioritization of programs towards the healthcare needs of the underprivileged, as primary care and maternal and health care packages. So these, whatever packages we give in terms of primary health care or maternal and child packages, most of them have to be seen that they have to be accepted. The surveys conducted in the mid-1990s in 40 countries showed that in the poorest, in fact, 20% of the households, 56% of childhood diarrheas were treated with oral rehydration, whereas on the other side of the picture, the richest fifth of the households, 71% of cases were treated with oral rehydration. What does this mean? This means that oral rehydration is the keyhole in treating diarrhea. The question is, one should be motivated enough or should be taught well for its acceptance in most of the families, and just like it is done in the richest families, it should be done in the poor families so that they could be benefited maximum. On an average, the country having higher overall coverage rates have also a very big rich-poor difference in immunization rates. Now, this is another factor which is very important, that there is, seen through the years, there has been only a marginal improvement in immunization rates, which have come up from acceptance of say 25-30% to say about 70-80% now, still not 100%. And the faster they do so, they will be the first to contract the benefit. Socioeconomic variations for reproductive health services. Actually, there is 5.2 times more medically supervised in the richest women rather than the poorest. The same thing in the reproductive health services, that the rich who actually don't really need so much of care, they would need minimal care, but at regular basis, they get the best quality care and the maximum care rather than the poorest of the women who actually want only part of that care to be given to them regularly. And the lowest coverage is seen in South Asia and parts of sub-Saharan Africa, whereas the socioeconomic dissimilarity in utilization are high in most regions except Central Asia and Eastern Europe. These are the areas where actually the parda system has existed from times immemorial. Now, Eastern Europe, Turkey, all these Muslim-based countries, plus Central Asia, you find that women are inside the house and hardly get out, so that they are not exposed to the requirements of what their body or what their people need. So therefore, acceptance is minimum. And in fact, the results of a demographic health survey between 1990s and after 3-5 years showed improved coverage and reduced rich-poor difference. For example, slowly this rich-poor difference has been coming down. For example, in Egypt, Kazakhstan and Nepal, improved coverage rates and reduced inequality for the deliveries attended by trained professionals are also seen. So therefore, the picture is not that sad as we think it is, but definitely with time, with health education, with the advent of the TV, with the advent of good theatres, we have seen that acceptance of healthcare and the outreach of healthcare is improving day by day. The non-demographic health surveys between the 1986, 87, 95, 96 showed actually, in fact, increased inequality in healthcare access in India. There is also evidence that suggests that the share of public health expenditures to the poor is lesser than the rich in the developing countries. Now, this always happens that whenever public health expenditure is done, it is being brought down to a minimum so that there is, in order to avoid wastage. Unfortunately, that particular share of public health expenditure is not enough for the poor to get the full maximum benefit of healthcare or programs. The poor gets less than 10% of public health subsidy in countries like Nepal, Guinea, etc. In primary healthcare, public health expending, there is also exists a pro-rich bias in most of the countries. So therefore, the rich get better health whereas the poor will get the minimal based. Inclusion of regional variations and quality difference in public spending will strengthen the evidence of rich getting proportionately higher primary health care as Asian incidence studies. The marginal increase in proportion of public health spending for the poor will have a greater impact. In fact, if this proportion, this is what it says, if the proportion of public health spending for the poor is given properly, in fact, it will have a greater impact in terms of utilization than the rich population. And public health spending has a positive impact, though marginal, on the poor population health, whereas there is no significant effect on the rich population. In the developing countries, in fact, you see a beautiful demonstration for you. The average doctor to patient ratio is actually one doctor for every 250,000 patients, which is completely unnatural, and it is less, because yet those same countries account for nearly 80% of over 5 billion mobile subscriptions worldwide. And for people everywhere, access to mobile phones, today this is the latest, access to mobile phones means better access to health information, which leads to a more uniform choice. Now this portion will come only when the people have been educated properly in order to utilize today's modern technologies. Now, for example, this particular chart shows public health expenditure in developing countries excluding funds from the development assistance. So basically, actually what has been happening is that certain countries have a minimum, they are all below the minimum level, but still it's that although the expenditure has been going up steadily, yet it is not sufficient to cover the complete needs of the society. And then when we talk about, when we want to balance health and education, health comes poor second, because public does not want to push into health. In public sector, government taxes and all, we go into health because these are all through the primary health centers and the public sectors, whereas the private sectors do not want to put in more into health unless it is in the insurance part. Whereas for education, we see a surge of educational activities today, because so therefore now private financing has come up in order to open good schools, expensive schools, and everybody, and it is available for every single person. So therefore, since it is well advertised, it is well accepted, whereas public financing, as far as this, public still goes to the more simpler government schools in all the sectors, but it is nowhere in comparison to the private funding. One thing we must talk that in spite of all these services which have been given and which have been improving over the times, definitely we have been able to make an impact, at least on the maternal deaths. We had said in the beginning that our goals should be seen to it that when we see the coming down of maternal deaths or other indicators, so this is one of the very important indicators. For example, in sub-Saharan Africa, you can see between 1990 to 2013, it has come from nearly 9 to 5. In Southern Asia, it has come from 5 to 1. Now, this is very good. This means that health, outreach of health has improved, acceptance of health services has improved, and finally, the acceptance by the mothers, by the new mothers, or by the families and by the older women of the users of health services have been accepted. So this is for the betterment. So less number of maternal deaths. Now, non-utilization of effective interventions, this is a very important thing, because in this, most important factor is the economic factor. Economic factor is one of the important factors in healthcare for underutilization, because people don't want to invest in health. They would rather invest in food, they would rather invest in education, and health per se of self or the other persons, unless it matters to a child. it becomes non-important. Now, determinants for preferences for healthcare, it is very important that it's not only the health care which is being provided, but the question of culture and gender issues also form a very important fact. That because depending on all this, it will depend whether, and especially the knowledge, the education, all these factors have a very important note on the acceptance of healthcare. And although we know now, for example, immunization rate in India is very poor in spite of the being free. The reason being lack of awareness of benefits reported by the mothers. See, one is that we have to know and we have to make them understand that this is good for them, this is acceptable, this should be acceptable by them. But without education, without a continuous education, health education to them, to tell them of the benefits, we will definitely get a poor quality demand response, because it could be either ways. There could be absenteeism of healthcare personnel, irregularity, inappropriate staff behavior, or irregular healthcare which is being given. Like I said, sometimes the weight machine is not there, sometimes the blood pressure machine is not there, medicines are not there, or there could be pilferage and inappropriate prescriptions. So because of all these, we must make it a point that healthcare, if it has to be acceptable, it has to be given in its complete presentation. Healthcare spending is very important for us and very important for the family, and it should never be a mismatch. It demands regulatory management and political reforms for delivering healthcare at good quality. And of course, health insurance, but health insurance is working in many other factors. But in our country, health insurance comes a poor second. And because nobody wants to pay for health, leave alone giving insurance, nobody wants to pay for the medicine. At current levels, out-of-pocket financing can only be provided to the poor groups only. Identification of such people, appropriate incentives could be given, and sometimes use of cash incentives for raising utilization have also been utilized, and maybe lowering the distance barrier, improving transport system. And for example, if you on fixed days, buses or could travel between the villages and the centers in order to provide at least a free ride for these. So in the conclusion, few points must be faced, that our developing countries are facing a double burden of communicable and non-communicable diseases with overburdened health system, aggravated by poor accessibility, affordability, inequitable distribution, and poor utilization of the existing resources. Various measures for improving this is better political commitment, insurance-based health services, and equitable distribution of health services. Most important, these health services have to be accepted by our nation, by our people, before they become a good program. So how can we improve our healthcare systems by in facing these challenges? The challenges of poor infrastructure, small budgets, high demands for healthcare services, lack of trained and skilled professionals, and by design, we can give sensible solutions and maybe cheaper solutions, scalable solutions which could give us different scales of the healthcare services which could be provided comfortably on different levels, and easy to learn and use solutions. So, ending this, thank you for visiting our e-Pathshala.